Let's now shift gears from the joint diseases to the bone diseases. From the bone diseases, we will be covering a few acquired diseases of the bone, including osteopenia, osteoporosis, osteomalacia, and rickets, and also osteomyelitis. So let's start. Osteopenia is defined as decreased bone mass and is defined radiographically as 1 to 2.5 standard deviations below the mean of the peak bone mass. Osteoporosis is defined as osteopenia that is severe enough to significantly increase the risk of a fracture. Radiographically, it's defined as bone mass at least 2.5 standard deviations below the mean peak bone mass. Osteoporosis can be localized involving single bone or joint, or generalized involving the entire skeleton. It can be secondary, but most commonly it's primary. The most common forms of osteoporosis, and they are primary osteoporosis, are the senile and the postmenopausal types. Based on the underlying etiology, the two types of osteoporosis, the primary osteoporosis and the secondary osteoporosis, are further classified into the subtypes highlighted in this table. As you can appreciate, primary osteoporosis includes postmenopausal osteoporosis and the senile osteoporosis, while secondary osteoporosis includes osteoporosis due to endocrine disorders, gastrointestinal disorders, drugs, and other miscellaneous causes. Of the endocrine disorders, as you can appreciate, there are the hyperparathyroidism, hypo and hyperthyroidism, hypogonadism, pituitary tumors, diabetes type 1, Addison disease, neoplasia, multiple myeloma, and carcinomatosis. Of the gastrointestinal disorders, malnutrition, malabsorption, hepatic insufficiency, vitamin C and D deficiencies, and idiopathic diseases. Drugs that are known to cause secondary osteoporosis include anticoagulants, chemotherapy, corticosteroids, anticonvulsants, and alcohol. Other causes include osteogenesis imperfecta, immobilization, pulmonary diseases, and the homocystinuria and anemia. Simply, osteoporosis occurs when the dynamic balance between bone formation and bone resorption tilts in favor of the bone resorption. Bone formation is the function of osteoblasts, and bone resorption is the function of osteoclasts. As you may know, the peak bone mass is achieved during the young adulthood, after which the bone turnover continues with a net deficit in the bone formation. This results in an average loss of 0.7% of the bone mass per year. This average loss is influenced by age-related changes. So the osteoblast, with aging, will have reduced proliferative potential and reduced response to the growth factor. This will result in a form of osteoporosis which is called senile osteoporosis. Senile osteoporosis is categorized as a low turnover osteoporosis because the problem is the decrease in the proliferative activity of the osteoblast, not the increased osteoclastic activity that will result in turnover. So it's a low turnover osteoporosis because there is no increase in the osteoclastic activity, but there is a decrease in the osteoplastic activity. The second factor is the reduced physical activity, and this is associated with normal aging and contributes to the senile osteoporosis. Genetic factors, calcium nutritional state, especially in adolescent girls who tend to have lower dietary calcium intake. Hormonal influences. It's known that in the decade after menopause, a yearly reductions in the bone mass may be as much as 2% for cortical bone and 9% for medullary bone. The postmenopausal reduction of the bone mass is thought to be hormonally related. So what happens? Estrogen deficiency in the postmenopausal lady increases both bone resorption by osteoclasts and bone formation by osteoblasts. However, the increase in the osteoclastic activity exceeds the increase in the osteoblastic activity, leading to high turnover osteoporosis. And it's called high turnover osteoporosis because of the increased bone turnover due to increased osteoclastic activity. This type affects 40% of postmenopausal ladies. This figure shows the pathophysiology of postmenopausal and senile osteoporosis. As you can see, there are several factors controls the peak bone mass, including physical activity, nutrition, genetic factor, patient's age, and hormonal status. With aging, there is a decrease in the osteoblastic activity, proliferation, and response to growth factors. All those will result in low turnover osteoporosis. While after menopause, there is a decrease in the estrogen levels, which will lead to increase in the inflammatory mediators that increase the osteoclastic activity and increases the bone resorption, resulting in high turnover osteoporosis. The hallmark of osteoporosis is histologically normal bone that is decreased in quantity. Rickets and osteomalacia. Both are manifestations of vitamin D deficiency or its abnormal metabolism. The fundamental defect is an impairment of mineralization and the resultant accumulation of unmineralized matrix. This contrasts with osteoporosis, in which the mineral content of the bone is normal and the total bone mass is decreased. Rickets is a disease of children, in which it interferes with the deposition of the bone in the growth plates. Osteomalacia is its adult counterpart, in which the bone formed during the remodeling is unmineralized, resulting in increased risk for fracture. Osteomyelitis is the inflammation and infection of the bone and marrow. It can be secondary to a systemic infection or primary isolated focus of disease, and this is the most common scenario. Osteomyelitis can be acute or chronic, and the most common etiologic agents are the biogenic bacteria and the Mycobacterium tuberculosis.